To the next talk, which will be given by Professor Petrov.
The talk, yeah.
Okay, Dr. Polomsky, total and subtotal stenosis. I wonder what total stenosis means.
Understand now.
So, dear colleagues, my name is Petr Polomsky, and thank you for the opportunity to present our work about carotid artery stenting in subtotal carotid stenosis. So, the endovascular experience in our center for the last 5 years is above 8,000 interventions at all. More than 750 of the cases are carotid artery stenting cases, including stroke intervention. 68 is the number of the patient with near occlusion or subtotal carotid artery stenosis that was intervened for this period of time. About the subtotal carotid artery occlusion is not invented, but described for the first time in 1953. Actually, then it was clear that this condition is the therapeutic challenge different than severe stenosis itself. Till now, there is no universal definition in the world about subtotal carotid artery stenosis. In the different articles, in the different seria, different authors point many of angio criteria for subtotal carotid artery stenosis, but the most constant one is distal collapse of internal carotid artery following a critical stenosis. It's from the angio. There are so many synonyms for the near occlusion, near total occlusion, 99% stenosis, functional occlusion, incomplete occlusion, and string sign of internal carotid artery, etc. Of course, two trials, NASCET and ESCT, are the cornerstone for the intervention of carotid artery at all, not subtotal, but every severe carotid artery stenosis. It's very important to say that these two trials, which are cornerstone for the intervention, use a different method to measure the severity of stenosis. The NASCET method actually measure the diameter of the internal carotid artery just after the stenosis and compare it to the narrowest segment of the artery. In case of near occlusion and subtotal carotid artery stenosis, the diameter just after the stenosis is collapsed, so the stenosis can be underestimated. What we know from here is that the severity of the stenosis from the angio, which is actually the percent of the stenosis, cannot be the only one criteria in order to recognize and diagnose subtotal carotid artery stenosis. Actually, I've tried here to summarize 4 most constant criteria in the different articles for subtotal carotid artery occlusions. The images are taken from our patients. First criteria is the late contrast in internal carotid artery, distal to the stenosis. Second criteria is internal carotid artery with smaller distal diameter compared with the contralateral one. Third one is the presence of intracranial collaterals from the non-target internal carotid artery. Actually, from the live case of Dr. Stankov, we see similar feeling of left anterior cerebral artery from the right. And the fourth criteria is a distal diameter of ipsilateral internal carotid artery less or equal to the compared to the external carotid artery from the such site. To be honest, in order to diagnose or to refer a stenosis as subtotal occlusion, we try to find more than 2 of these criteria in our series of 68 patients. These stenoses are divided of 2 main groups. It's very important. First of all, there are stenosis with a complete collapse of carotid artery distally to the lesion, which are called near occlusion with full collapse and other new occlusion without full collapse. This is cornerstone of probably newest publication about treat or not treat this type of lesions. Till now, a number of current guidelines recommend actually conservative treatment in patients with near occlusion with only single ipsilateral vascular event. But to be honest, the optimal treatment of the patient is unclear. What we know about the pathophysiology, each severe carotid stenosis can progress to near occlusion, and each near occlusion can progress to total one. Actually, the histological finding in most of the cases is atherosclerosic lesion, which is severe, not occlusion, but in some cases, the pathological finding is actually a recanalized thrombosis in this patient. During the intervention endarterectomy, intraoperatively measured pressure distal to the stenosis is usually higher in patient with near occlusion, and I will try to explain this phenomenon. Actually, the collateral blood flow is very important in this patient. There are 2 types of collaterals that involve circle of Willis. Here you may see the relation between the grade of the stenosis, severity in percent, and frequency of the collaterals reported in the measurements. So, 2 types of collaterals. First of them are involved circle of Willis, and the second one are different than circle of Willis. They are most biggest of them are through middle arteria meningeal medica, ophthalmic artery, or occipital artery. There is just one publication trying to explain the phenomenon of subtotal carotid artery stenosis. It's by Spencer and College. They describe a theoretical model according which if the stenosis is severe enough and this will progress to the large drop in the pressure distally to the stenosis and reimbursement of the blood flow from the contralateral part through the collaterals that we describe. The gradual decrease, which is mandatory for this model, in the severity of the stenosis will lead to the progression of the near occlusion from the near occlusion without to near occlusion with full collapse. This is the theoretical model. So there are 2 mandatory things. First of all is the gradual decrease in the antegrade flow, which means actually slow progression of the stenosis. And the second thing, the circle of Willis and the collaterals must work normally, so there must be not any type of anomalies on this level. Just in order to make some point between the coronary versus carotid lesions. In case of coronary lesions, I will point only single non-infarction coronary lesions. There is no direct relationship between the degree of the stenosis and the risk of some event, in this case myocardial infarction for the patient. But what we know about the carotid stenosis, there is a direct relation between the degree of the stenosis of the vessel and the risk of some cerebrovascular event in this patient. It is very interesting what is the mechanism of TIA and stroke, every cerebrovascular incident in this patient with neuro-occlusions. Probably what we know is that neuro-occlusion can progress to total occlusion. So this is probably most suspected mechanism in patient, but it's very interesting that I actually found only one publication that compares a series of 4 patients with neuro-occlusion with full co-ops, which are actually angiographed before and after the incident, without any treatment, different than optimal medical treatment. And actually what the author found is that none of these 4 patients has a progression of near occlusion to the complete occlusion. So probably the embolic and excuse me, hemodynamic mechanisms are also involved in the pathophysiology of the cerebrovascular events during these patients. Actually, return back to the NASCET and ESC trial before, it is very important to point that a very small number of the patients in these trials had neuro-occlusions. Only 264 cases of neuro-occlusions are included in this trial, and only 16 of the patients had a real neuro-occlusion with full collapse of the distal internal carotid artery. Actually, these trials didn't prove any benefit from the endarterectomy for the patient with neuro-occlusion, but the data is so insufficient for statistical analysis. So, to be honest, this trial cannot give a light spot on the question if it's necessary to intervene or not these arteries. Actually, in 1983, the work by Ringelstein and colleagues, which focus on the surgical treatment of subtotal carotid artery stenosis, followed 9 patients with neuro-occlusion with full collapse, and they actually just follow up this patient. They give optimal medical treatment, but nothing more. So the author reported 6 of 9 patients for a very short period of time, 3 months, have a worsening in the neurological deficit, and in particular, 2 of them have crescendo transitory ischemic attacks, 2 have amaurosis fugax, and 2 patients have the lesion progressed to total with some kind of neurological deficit, additional neurological deficit. In 1989, other clinical studies trying to make some game change in the treatment of neuro-occlusions. Actually, 9 patients with neuro-occlusion in this study undergo surgical treatment, and 3 had a recurrent ipsilateral stroke. In 2015, group of 10 patients with neuro-occlusion with full collapse or just followed up, and 40% of them have ipsilateral stroke for just 1 month of follow-up. The first large meta-analysis for the patient with neuro-occlusion, which actually head-to-head directly compares optimal medical treatment with coronary artery stenting and optimal medical treatment with endarterectomy, actually reports incident ratio with 1.6 for coronary artery stenting and incident ratio similar 2.2 in case of endarterectomy for such patient, which is statistically significant finding that the prognosis of these patients is better than with surgical treatment compared to the optimal medical treatment. Other meta-analysis published in 2020, which is based on 33 publications from the period of 2025 and 2020, we report the incidence of the stroke after endarterectomy about 1.5%, incidence of stroke after carotid stenting 1.8%, but in any case, this is probably more than 6 times more than incident of stroke after only drug therapy, which is 8.4%. This is the largest meta-analysis that compares head-to-head optimal medical treatment with other treatment of carotid arteries with full collapse. The authors also report that there is statistically significant difference in the terms of stroke rate after any surgical treatment or stenting and the year of the publication. So the incidence of stroke progressively dropped between 2005 till 2020, which is the probably sign that the procedures becomes less invasively. Here is one of our patient with right-sided hemiplegia for approximately 1 day, one ineffective fibrin releases in the acute phase of the stroke. Here you can see the actually near occlusion with the thrombus involved also in this case. So the lesion was crossed with run-through hypercoat guide wire and a fine coarse microcatheter. After that, the protection with after that the Paladin balloon was used because the lesion contains thrombus formation itself, and the implantation of one exact stent was done 9 millimeters, 740 millimeters. So this is the final result in this case. With NICS-4 at 30 days after the incident. About the conclusions, we know that near occlusion carries a worse prognosis than any severe occlusion of the carotid artery. The near occlusion is directly related with the cerebrovascular incident, and the treatment of these lesions carry higher risk of complication as hyperperfusion, hemorrhagic stroke, extravasation compared to the treatment of severe but not near occlusion. The clinical trials that are cornerstone for the treatment of carotid artery stenosis didn't include enough patients to give us statistically relevant data about what will be the treatment of these lesions. And the recent data showed benefit from stenting or surgical treatment compared with conservative one. So probably in the future, the recommendations and guidelines will be, the indication will be extended. Thank you.
If you allow me just a comment, Dr. Polomsky didn't show, but in these 68 patients, we compared the 68 patients, so near occlusion group, compared to the non-near occlusion, so typical stenosis up to 90%. And this fear about hyperperfusion, hemorrhage, and so on, higher mortality, higher complication rate, in fact, didn't do true. We had no any difference. We don't have no one hyperperfusion, no one hemorrhage, and in fact, it's definitely feasible. We are doing, in fact, in case we make a statistics, about 5% of our carotid activity is due to stenosis with near occlusion, but like mentioned here, without full collapse. So we are treating such kinds of patients with only capacity of accepting the new flow. So probably this is the reason not to have hyperperfusion, because in case the vascular activity is totally blocked, in this situation we have a real risk of hyperperfusion. But in case we have a good vascular reactivity, the risk is not so high. And we are doing the procedure since 10 years. So I believe there are some patients with real indication.
I guess we all agree that patients with critical stenosis have to be treated. With near occlusion, it depends whether the blood coming to the occlusion is reaching the brain.
Exactly.
So maybe it's a phenomenon, and maybe even if at the time of the diagnostics we don't see any contrast coming into the brain, it doesn't mean that 2 hours later we may have it. So maybe there is good potential for embolization nevertheless, because otherwise we will rely only on hemodynamic principle to improve the perfusion. And it is very tricky to predict whether the hemodynamics will change after the opening the vessel.
Yeah, there are some methods, some MRI and CTA perfusion that are trying to predict what will happen in case the carotid is open. And there was a commentary, editorial, about 5 or 6 years ago by Jay Yadav, that in case the vascular capacity based on the CT MRI perfusion is maintained, this patient has the potential to have a benefit from the intervention.
But what I'm saying that if you keep it simple, if we see some flow, we have to open it.
Yeah,
okay.
In order to keep it really simple, it's true. It's more or less true. I see Donald. Donald, what is your opinion as a surgeon? Do you sometimes operate near occlusion carotids?
I think it's a very, very important topic, and I'm very pleased that you've put this onto the agenda, Ivo. And the late British Prime Minister Winston Churchill had recurrent strokes in the presence of total occlusion of both of his carotid arteries. And perhaps or perhaps not, he had subtotal occlusions, I don't know. But it's cerebrovascular insufficiency rather than embolic disease, and is extremely well treated if you can get more blood up to the brain, and the patient's symptoms are transformed. So I do remember that many years ago, Dr. de BEC and Dr. Dietrich used the external carotid artery, and they, in the presence of total occlusion of the internal carotids, they would surgically improve a narrowed origin of the external carotid artery to show, just as you have seen, the collateral flow through the external carotid artery towards the brain. And later on, yes, that's true, Klaus, but later on, I did a small series and published it with Dr. Dietrich of stenting the origin of the external carotid artery in the presence of total occlusion of both internal carotids. And the patients all did extremely well because of this, and one of them was transformed. So I'm a great fan of this topic. It's not aired enough, and well done, and a great presentation.
Thank you, Donald. Thank you very much. Some more?
I guess it's time to move forward.
Yeah, some more comments?
Guess not.
Okay.
Everybody's convinced to start treating all occlusions now.